Metastatic patients will often be referred to surgery under the following circumstances. For subsets of patients, they will still have their primary in place. That is, the original kidney tumor has not been removed. Those patients, if they have a good long-term response to systemic treatments, will often be asked to have their primary removed. That is done both for sometimes symptomatic reasons, meaning they're still having bleeding or ongoing pain, but also we think it does provide benefit to the patients, and many studies have shown this, to remove the primary because that is the source of all the metastatic disease. And there's a thought that the primary tumor does harbor the most ability to develop resistance. So there's a strategy long-term to remove it whenever feasible. The other scenario where a surgeon might be called in is if a patient has a single site of metastasis, for example, that remains persistent, or they have a response in many sites, but only one or two sites remain resistant. Those are scenarios in selected patients where they may undergo surgical resection. For example, a lung lesion might be resected after many years of treatment or many months of treatment, and that can be of benefit in the selected patients. Again, patient selection is the key, and working in a multidisciplinary fashion is very important in this context. When a new site of disease emerges or a disease remains persistent despite other responses, surgery can play a role as well as radiation or ablation. The choice of those revolves around a few factors, including feasibility of surgery, safety of the surgery itself, as well as patient preference and access to these options. We often will use different strategies for different locations and different treatments. And often patients that have had surgery before will undergo other forms of treatment because they've already developed scar tissue or other things from that. But for example, a lesion in the lung can be treated very effectively with all three of those modalities. And it really boils down to the need for tissue sampling as well as the morbidity of each of the procedures. It is very important in kidney cancer, especially in advanced kidney cancer, to be part of a multidisciplinary team. These are often called tumor boards or multidisciplinary team management. At MSKCC, as many other academic centers, many of the surgeons see patients the same day as the medical oncologist, and we often share patients for many years together. In fact, when I see a new patient with advanced kidney cancer, they'll often see the medical oncologist the same day as me, and we'll often discuss the case together. For rare and complex cases, we often will present them to a group setting where the patients will be reviewed by a group of surgeons, medical oncologists, radiologists, pathologists, and radiation oncologists and interventional radiologists. All of these may have opinions to weigh in on and wisdom to impart, and a decision can often be made as a consensus when it's clearly a difficult or unusual case. It is very important for patients with rare tumors, especially in which kidney cancer has several of, to seek out a scenario where they can be reviewed in a multidisciplinary fashion. In terms of when a surgeon might get involved again and the type of surgeon after surgery has been completed, it will depend a little bit on the location and the comfort level of the urologist, the person who performed the original surgery. Many urologic oncologists will feel comfortable going back into the area where the kidney was formerly and removing a mass that might have occurred in the, for example, the bed of where the kidney was, or the fat or muscles around it. When tumors involve other organs, such as the bowel, the liver, the lungs, the bones, those are often referred to other surgeons that have experience operating on those organs more regularly. And usually the urologist may be involved in that surgery itself to provide some guidance and also to inspect the area where the prior surgery was. But often those patients will see and be treated by other surgeons as their main doctor in those scenarios. The question about brain metastasis and surgery is a bit of a complex one and has been evolving over time, given the improvement in our ability to target tumors with stereotactic radiation, often called stereotactic radiosurgery. This provides a very precise targeting of brain tissue with radiation fields and can be very effective. However, certain brain metastases can be large and quite symptomatic, and those patients are often best served with surgery. Often there will be a combination of both, with surgery being the first maneuver and followed by what's called adjuvant radiation, which means that surgery can often be incomplete in the brain or limited in the brain, and the radiation can often be used to help treat the area that was operated on. So both radiation and surgery play significant roles, and their choices are really dependent on imaging and tumor factors. For patients that have had prior kidney surgery, developing new kidney tumors can be very scary and frustrating. About 3 to 5% of patients that have had kidney surgery will develop another tumor either on the same or opposite side. Those patients need lifelong surveillance. And when they do occur, we will often treat them early because it's a solitary kidney. Or if it's a patient that's had a partial nephrectomy, we can often watch them because they have a good amount of kidney already still. However, the choice about whether to intervene will depend on several of the factors that I mentioned earlier in terms of the choice to operate in the first place. If a patient is young, we will often be very aggressive and treat anything that we see in the kidneys. However, as the patients get older and live longer, if they develop a new tumor and they're in their 80s, for example, we will often just watch those because that probably will not be the determinant of their life expectancy. So it's a case by case decision, but in general, we try to watch patients carefully and intervene when we can early. Surgery for metastatic kidney cancer patients continues to evolve. Before we had such effective treatments that involved immunotherapy and anti-blood vessel medicines, we often operated on basically everyone that could have undergo surgery. We learned over time, however, that that's not the best choice for many patients. And now with stronger treatments, we are often deferring surgery early on, unless the patients are young, healthy, and have low volume of metastatic disease. For many patients, they will require upfront systemic treatment. And then the choice about when to have surgery on their kidney will depend on a variety of factors, including their response, their preference, their symptoms, as well as discussion between the medical oncologist and the surgeon. We've operated on patients following systemic therapy as early as 3 months and as long as 2 to 3 years following systemic therapy. Each patient is weighed individually and each decision is made as a group.